Okay guys, today we are going to discuss pituitary disorders. First of all, let's review our pituitary features. Pituitary gland, which is a pea-sized gland present in the mid of the brain, hanging from the stalk. The location of pituitary gland is the sella turcica, which is a part present in the center of the base of the skull. It is basically a groove or tubercle kind of thing in which the pituitary gland resides. Here you can see this is the sella turcica. Okay, so anterior pituitary gland has 5 types of cells. The lactotrophs, which produce prolactin. As you know that prolactin stimulates the breast to produce milk. And then gonadotrophs, which stimulates the anterior, which produces FSH and LH, which stimulates estrogen production in females and testosterone production in males. Then corticotrophs, as name indicates, are adrenocorticotropic hormones, which stimulates the cortisol production from the adrenal gland. Then the somatotrophs are basically growth hormone producing cells, which then causes growth, stimulates growth of the body tissues and muscles and organs and the whole body and bones. Then the thyrotrophs are the cells which produce TSH, thyroid stimulating hormone, which has its function that it acts on the thyroid gland and stimulates the production of T3 and T4 thyroid hormones. Then basically there are 2 basic hormonal disorders of pituitary gland. First ones will cause hypopituitarism, and the other one will cause hypopituitarism. You can imagine that when there is hyperpituitarism, that all the hormones will be produced in excess from its normal range or levels. Then as a result, the body will be act accordingly. Like if there is more prolactin, then more milk will be produced. If there is more growth hormone, then there will be more thickening of the tissues and organs. And if a child is in growing age, then he will develop gigantism. These are the things that a person develops because of excessive secretion of pituitary hormones. So hyperpituitarism is excess secretion of pituitary hormones. Most commonly, the hyperpituitarism is caused by adenomas, adenomas are basically benign tumors of anterior lobe of pituitary gland, in which the most common tumor is of prolactin producing cells, that is lactotrophs. So this tumor is called prolactinoma. Then there are growth hormone adenoma, thyrotroph adenoma, ACTH producing adenoma, and gonadotroph adenoma. Adenomas are of 2 types on the basis of their size. If their size is less than 10 mm, then it is a microadenoma, and if it's greater than 10 mm, then it is a macroadenoma. We differentiate it like this because the macroadenomas produce pressure symptoms on the surrounding structures of pituitary gland, which then causes, as you are familiar with the term, bitemporal hemianopia. It is basically visual field defect of temporal side. It is caused mostly due to the adenomas of the pituitary gland. So first of all, we are going to discuss prolactinoma. What prolactinoma does is a hyperprolactinemia, that is excessive secretion of prolactin by the pituitary gland. There is a normal range and above it, if the prolactin is above it, then it is called excessive. Greater than 390 mU per liter is considered to be excessive secretion of prolactin. What happens is that basically hypothalamus influences the production of prolactin. How does it do it? He produces 2 hormones. One is thyrotropin releasing hormone TRH, and other is dopamine. both the TRH stimulates the release of prolactin, whereas the dopamine inhibits the release of prolactin. Usually the prolactin is under the inhibitory effect of dopamine. That is why its levels are well controlled in men and non-pregnant females. It only raises in a lactatory female or in lactatory females and the pregnant ones, other in normal conditions. Otherwise they can be otherwise prolactin can be raised in abnormal conditions, like we have said that in prolactinomas. Okay, here are some causes of hyperprolactinemia. Hyperprolactinemia can be seen in pregnancy, lactation. Prolactin is also increased during sleep as dopamine is decreased, so prolactin is released more, and in stressful conditions and in coitus. Okay, then drugs that induce, basically, as you know that dopamine decrease if there is more dopamine, then there is less prolactin. So when you give a dopamine antagonist in any condition, that usually antiemetics like metoclopramide are given in to control nausea and vomiting. So in such patients, if they are taking metoclopramide for a long term, the dopamine levels will decrease, and as a result prolactin will increase. So whenever you are having a patient who is complaining of prolactin hyperprolactinemia or galactorrhea, then you must rule out that the person is whether having some drugs for for dopamine antagonism for vomiting or nausea, or there are some other problems. You always have to rule out that, and as well you have to rule out TSH. Okay, so antipsychotics, there can be the patient may be using antipsychotics which can decrease dopamine, and estrogen, which has its negative feedback effect on the pituitary gland. So as a result, prolactin may rise, and methyl dopa and reserpine. Okay, pathologic things that cause hyperprolactinemia are most common is prolactinoma, which we have discussed now, and then hypothalamic diseases. And the hypothalamic disease, as you know that if there is more TRH for some reason, then it will stimulate the prolactin production, like there you can say that primary hypothyroidism. What a primary hypothyroidism does is that there is a thyroid problem in which the thyroid gland is unable to produce thyroid hormone, so the hypothalamus is activated, that the thyroid gland is not functioning normally, so I have to produce more TRH to stimulate the thyroid gland, and as a result, along with the rise in TSH and thyroid hormones, there is also a rise in prolactin levels. And chronic renal failure, which decreases excretion. So as a result, these all conditions will lead to hyperprolactinemia. The first thing we are going to discuss is prolactinoma. Prolactinoma, which is a benign tumor of pituitary gland that secretes excess of prolactin. It is the most common functioning tumor or adenoma. Here you can see that it is the tumor of pituitary gland. This is the pituitary gland and posterior lobe, and this is the anterior lobe, and you can see that the size of the anterior lobe has been increased. This is prolactinoma. So clinical findings that you get in prolactinoma, there are some differences in male and female. Like in females, you will have secondary amenorrhea. Secondary amenorrhea is because the patient, when there is raised prolactin produces a negative feedback effect on FSH and LH. As a result, these or GnRH, gonadotropin releasing hormone, which then produces a negative feedback on FSH and LH, and as a result, these are decreased. So when these are decreased, then there will be less estrogen, because estrogen is produced with the stimulation of FSH and LH. there will be there will be less estrogen, then there will be no maturation of ova, and there will be no ovulation. So you may not have secondary amenorrhea in all the conditions, but you will always have anovulatory cycles. The patient will be suffering from anovulatory cycles. Okay, so when there is ovulatory cycles, there will be infertility, and as you can see that the patient is having prolactinoma, prolactinemia, hyperprolactinemia, then so he will have galactorrhea, that is excessive secretion of milk without the lactation period. The patient will have increased weight and dry vagina. Okay, these are the symptoms that he will complain, whether it is a microadenoma or macroadenoma. Okay, males develop erectile dysfunction or hypogonadism. There is loss of libido. Libido is sexual desire, so their sexual desire is lost. There is decreased facial hair, and they may develop gynecomastia, as you can see that prolactin and all these hormones increases the breast size, so they may develop gynecomastia. Okay. Then comes the pressure symptoms. Pressure symptoms are like blurred vision. Patient may have a blurred vision because of the pressure effect, and he may have a headache because of the compression of meninges when the tumor gets too large enough. And bitemporal hemianopia, in which there is a tunnel vision, that is the nasal fibers are intact, so nasal vision is intact, but the temporal side of the field vision are defected. Patient can only see like a person can see in a tunnel, that everything is dark from the in the surrounding, and only a central vision is present. So that's how a person presents to you. Here you can see the central vision, that this is the temporal side which is defected, and this is the central vision which is not defected. Estrogen. So what estrogen does is, estrogen prevents activation of osteoclasts normally. So osteoclast normally, so when there is decreased estrogen, as you can see that it inhibits the FSH and LS, so as a result there will be decreased estrogen. So when there will be decreased estrogen, osteoclast will be raised, and osteoclast causes breakdown of a bone, and when they will cause a breakdown, it will cause osteoporosis, and patient will be prone to fractures. So the patient may complain of bone pain, or may complain of fractures, or unable to move properly, things like that. There is decreased spermatogenesis due to decreased testosterone in males. As you know that FSH and LH stimulates testosterone production in males, and prolactin has caused a decrease in FSH and LH levels. So no spermatogenesis as a result, no sexual desire, and loss of hypogonadism, that gonads will not develop, and no erectile, and there will be erectile dysfunction. Okay, diagnosis. So how will you diagnose? First of all, there is a proper way of ruling out the problems that the patient may be having. First of all, you have to rule out pregnancy, that whether your patient is pregnant or not, because in pregnancy prolactin levels are raised. Then you have to rule out the drugs, and which you will do through the medication history. You will ask your patient that whether he is taking some drugs for nausea or vomiting, or for antipsychotic drugs, or rizapine or methyl dopa, any kind of drug he is having. You have to take that history to rule out that whether it is from whether it is a side effect of some drug or medication, or whether it is from the pituitary gland. Then you have to rule out hypothyroidism. So for that you will do the TSH levels. If TSH levels are raised, then it means that the TRH is increased as well. So as a result, the prolactin will be raised. You must know the prolactin levels, which are normally less than 500 mU per liter. But in microadenoma, there are between 1000 to 5000, and in macroadenoma they are greater than 5000 mU per liter. MRI is the last thing that you do in a hormonal condition, and it is used to visualize the size of the tumor. Treatment. First of all, you will start with the medical treatment. For medical treatment, you always give dopamine agonist, because dopamine it produces an inhibitory effect on the prolactin levels. So first of all, start with bromocriptine or cabergoline. Basically, cabergoline is similar to bromocriptine, but it has lesser side effects than bromocriptine. So nowadays it is preferred. And it also cabergoline doesn't have the heart valve side effects as well. Then comes the surgical treatment. If you cannot treat the patient from medical treatment, if there is a failure, and if the patient develops pressure symptoms, then you have to go for the surgery, in which you do transsphenoidal surgery. You don't it's not a typical one. You approach through the nose and the sphenoidal sinus, and you remove the pituitary tumor. But the side effect of this surgery is that because you have removed the pituitary tumor, the patient will develop pan-hypopituitarism. That is, all the hormones levels will decrease, but pan-hypopituitarism is better than hyperpituitarism. So we do this. Okay, so there are two indications of surgery. First is when the drugs fail, and second is when the patient develops a microadenoma or pressure symptoms start to appear. Okay. If prolactin levels remain elevated after surgery, then radiotherapy is indicated. In case of pregnancy, if there is microadenoma, then stop dopamine agonist therapy if you are giving any. And if there is macroadenoma, then continue the therapy with monitoring prolactin levels, as it may increase under estrogen stimulation. Thank you.